Good evening, friends. I am Dr. S. Rajasundaram. I am a surgical oncologist. Right now, working as Director of Clinical Global Hospital, Health City, Institute of Global Oncology. So, today we are going to discuss about a very important topic, which is colorectal cancers. So, colorectal cancer, why it's an important topic is it's rising in trend, and like previously we are known for oral cancers, lung cancers, and breast cancer and cervical cancer in women. But now, because of the modified lifestyles and lifestyle changes, the colorectal cancers are on the rise. So, I will briefly discuss about what is colon and rectum and what is the function, what is anatomy, and how the cancers are formed and what is the trend that is treated. So, colorectal cancers, colon and rectum is nothing but the otherwise called as large intestine. It's just around 5 feet length. So, the intestine starts like this: esophagus, this is the food pipe, and then stomach and the small intestine, then starts as large intestine. So, large intestine is around 5 feet length, which is consists of 5 parts, which is ascending cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and final part is called rectum. The final 15 centimeters is called rectum, and rectum because it's a straight structure. And the colorectal cancers are commonly discussed together because most of the time they behave in the similar pattern, though there are some variations, but generally they behave in the similar pattern. So, colorectal cancers are discussed as together. What is the function of the colon and rectum? So, normally when we eat food, it gets digested in the stomach and intestine, and then it gets the last material comes into the colon and rectum. So, the colon absorbs the water and salt from the food content, and the final part is continuous stools, and then comes and stays in the rectum. And the end of the rectum is called anal sphincter, which has got a smooth muscles, and sphincter is controlled by the brain. And whenever we have a urge to pass stools, and when the situation is all right, the sphincter relaxes and we pass stools. So, this is how the colon and rectum functions. So, mainly it's a reservoir, and it is for absorption of water and the salt. So, this is the main important function, because otherwise we will be passing motion very often. So, what the pathology it happens is, I have told you about the anatomy and physiology. What the pathology, how the cancers can come. So, normally cancers can arise as cancer in situ, or it can arise from a polyp. So, what are polyps? Polyps are just like a mucosal folds with mucosal elevations that occur in the colorectal mucosa. So, if you take colon and rectum, the mucosa it's formed by 5 layers. So, mucosa, submucosa, lamina propria, and then muscular layer, 2 layers of muscular layer, and then adventitia. So, it is the innermost part is called mucosa. There it starts as a polyp. There are various kinds of polyp. One is adenomatous polyps. In that there are 3 types: tubular, tubular villus, and villus polyps. So, most of them, the adenomatous polyps can turn into malignancy. It starts as a small polyp and slowly grows, and then over a period of years it can turn into malignancy, that is cancer. So, second is the villus polyps. Definitely they may turn into cancers. So, we have to really check whether we have polyp. If there is any polyp, we have to remove it colonoscopically, and then if there is any other polyp, it has to be observed whether it's changed into cancer or going to change into cancer, and it treated accordingly. And other polyps are hyperplastic polyps or inflammatory polyps. They don't turn into malignancy. So, there are various polyps, and this is the commonest pre-malignant condition. The second is maybe constipation. All these things can lead on to colorectal cancers. Why colorectal cancer is on the rise is because of the westernization that we follow. So, we take high calorie diet, high fat diet, a lot of red meat, and most of the processed food. All these things with a change in lifestyle, sedentary lifestyle, unhealthy lifestyle, smoking, and less of physical activity. All these things produces more of colorectal cancer. That is why, which was a very rare disease in our country, it's become a very common disease in our country now. So, colorectal cancers. So, if you take the incidence now compared to 2004 and 5, 2014 and 15, there is 25 to 35% increase in colorectal cancers, which is alarming. So, which is going to go and increase more and more. If you take the 5-year survival rates, so 5-year survival rate is almost the same as a 40% around for the last 5-10 years. There is increase in treatment modalities, but still the 5-year survival, maybe because the patients are coming little too late. There are 4 stages of cancer: stage 1, 2, 3 and 4. If it is stage 1, if it is a polyp turning into malignancy, we can treat colonoscopically, and we can get away with that. So, how do you make a diagnosis of it? Is always we have to do a procedure called colonoscopy. That is, you pass a small tube endoscope from the anus and then check the entire colon. Can be done under anesthesia without any pain. And once we check that there is any polyp or any malignancy, then we take a biopsy, confirm it. Then we do a CT scan or whole body PET scan when indicated. Then if we make a diagnosis of adenocarcinoma or mucinous carcinoma or acidic cell ring carcinoma, then we make treatment for part of it. So I told you there are 4 stages. If it is a very early stage, stage 1, we can do treatment endoscopically or limited resections, and we can do a transanal resection without removing the entire rectum. And if it is little advanced, there are 3 modalities of treatment: surgery, chemotherapy and radiotherapy. The good thing is it responds well to chemotherapy, it responds well to radiotherapy, and it is most of the time it's treated well with surgery. We'll take up surgery first. So surgery is depending on the stage. So if it is stage 1 and 2, the tumor spreads. If it is stage 1, it is confined to the mucosa and submucosa. If it is stage 2, it spreads through the serosa, and then if it is going into the lymph nodes, then it becomes stage 3. Or if it is goes in the blood through the blood vessel into the liver, commonly into the liver and to the lungs, it becomes stage 4. So accordingly we make the treatment planning. So if it is stage 4, the treatment is first is chemotherapy plus targeted therapy. We have to assess KRAS mutation and NRAS mutation, BRAF mutation, and these are all tests done by the biopsy sample. And according to the mutation, we treat the patient with. We find out whether it's a wild type or mutant type. Accordingly, we give targeted therapy and chemotherapy with stage 4. Stage 3, we give a concurrent chemoradiation, that is chemotherapy plus radiation, especially in rectal cancer, to shrink the tumor nicely, and then go for surgery so that you can preserve the sphincter. Our aim is to, in a rectal cancer, to preserve the sphincter so that you avoid permanent colostomy. So when it comes to surgery for colon and rectum, so if it is early stage cancer, we perform surgery as upfront. So most of the time it is laparoscopic surgery or robotic surgery. We remove the colon or rectum either laparoscopically or with robotic surgery, and then we reconnect the colon to the rectum, the end part of the rectum, or colon to colon, so that we avoid colostomies. Colostomy is the bags which are kept to pass motion in the anterior abdominal wall. So our aim is to avoid colostomy. Previously, if you take 10 years back, most of the patients with rectal cancers had been having only colostomies and permanent colostomies, but with the modern treatment modalities, we try and avoid colostomy. So the permanent colostomy rate has come down to 10%. So 90% of the time we preserve the sphincter with neoadjuvant chemoradiation or with good surgery if it is early stage. So I have told you about surgery and chemotherapy and radiotherapy, and stage 4 if it is stage 4 targeted therapy. So once this treatment is done, the patient, if it is primary surgery, if the stage comes to stage 3, the patient will need adjuvant chemotherapy and sometimes adjuvant radiotherapy. If the patient comes, they have to come for follow-up every 3 months. We do a blood test called serum CEA, carcinoembryonic antigen, and we do the scans every 6 months, every 1 year. We do CT scans and make sure that the disease under control or is not there. And if the disease, if it reoccurs, then we treat according to the recurrence. If it is liver disease, we may either go for surgery or go for targeted therapy followed by surgery. So accordingly, so follow-up is very, very important. So 5 years we follow up them for every 3 months, then once in 6 months. If there is any other polyp during the follow-up period, then we remove it endoscopically, colonoscopically. So this is the in toto the treatment in short about colorectal cancers. And the main message that I want to tell you is we should not follow westernized lifestyle. We should have a healthy food and a healthy well cooked food, not processed food, and we should eat a lot of vegetables and fruits and fresh vegetables, have a good exercise and good amount of lifestyle with good sleep and relatively stress free life. As we adapt all these things, probably we may avoid colorectal cancers. And if you go for regular screening, then we can pick up lesions at a very early stage, at a polyp stage, and then we can remove colonoscopically, which is very, very easy. So I think I have given you a gist of commonest cancer in the colon and rectum, which is adenocarcinoma. The other tumor that can occur is a carcinoid tumor, GIST, gastrointestinal stromal tumor, or it can be a lymphoma, sarcoma. All these things are very rare tumors which we don't have to discuss or worry about it. So adenocarcinomas are very common tumors, and if you pick up early, it can be treated early. How do you make a diagnosis? Whenever there is the earliest symptom, you should consult the doctor, right doctor. So if there is altered bowel habits, if there is bleeding while passing stools, or if there is diarrhea alternative with constipation or constipation, don't think that all that is hemorrhoids or fissure. Go to a proper surgeon, consult an oncologist or medical gastroenterologist. Make sure that they do proper investigation, sigmoidoscopy, colonoscopy, come to a conclusion whether it is cancerous or non-cancerous, and then reach a cancer surgeon and then make sure that you get the proper treatment. Thank you.